Why does the rotator cuff re-tear after surgical repair in up to 30% of patients? Why does Achilles tendinopathy last 18 months when a muscle strain heals in 6 weeks? Why does plantar fasciitis persist for years despite physical therapy and multiple cortisone injections? The answer isn't bad luck. It's tendon biology. And once you understand it, you understand why regenerative medicine, done right, is not just hype. It's a rational biological response to a real structural problem. I'm Dr. Trevor Turner, interventional sports physician at Pravida Health. I treat a lot of chronic tendon problems, rotator cuffs, Achilles, patellar tendons, plantar fascia, and the most useful thing I can do for patients before we discuss any treatment is explain why their tendon didn't heal on its own. Because once you understand the biology, you understand why some treatments work and others, like repeated cortisone injections, are actively counterproductive. Tendons are extraordinary structures. They transmit forces of 10 to 12 times your body weight with every step when you run. To do that, they need to be incredibly strong and stiff. And the biological properties that make them strong are the same properties that make them terrible healers. Problem 1. Almost no blood supply. Muscles heal quickly because they're richly vascularized. Healing requires blood. It carries oxygen, nutrients, and the cells that repair damage. Tendons have almost none. The watershed zones, the mid portion of the Achilles, the insertion of the rotator cuff, the proximal patellar tendon, are the areas with the least vascularization. They're also exactly where most chronic tendinopathy and tears occur. That's not a coincidence. Poor blood supply and poor healing. The areas under the most mechanical stress also have the worst biological repair capacity. Problem 2. Type 1 versus type 3 collagen. Healthy tendons are type 1 collagen, strong, parallel, organized. When a tendon repairs itself, the first thing it lays down is type 3 collagen, weaker, disorganized, scar-like. Over 12 to 18 months, this should remodel to type 1. In chronic tendinopathy, it doesn't. The result? The healed tendon is structurally inferior to what it was before injury, biomechanically vulnerable, more susceptible to re-injury. Problem 3. Tendinopathy is not tendonitis. This is the most important clinical distinction. Tendonitis means active inflammation, acute pain, swelling, redness, heat. Anti-inflammatories make sense for tendonitis. Tendinopathy means chronic degeneration without active inflammation, disorganized collagen, mucoid degeneration, failed remodeling. When you inject cortisone into a chronically degenerated Achilles, you're suppressing inflammation that isn't there, and you're potentially disrupting the collagen structure that is there. Multiple studies document increased tendon rupture risk with repeated corticosteroid injections for chronic tendinopathy. Cortisone works for acute flares. For chronic tendinopathy, the long-term evidence is deeply unfavorable. So what does regenerative medicine actually offer? PRP delivers concentrated growth factors, PDGF, TGF-beta, VEGF, IGF-1, directly into the tendon tissue. These signals activate tenocytes, stimulate collagen synthesis, promote neovascularization, and reduce the chronic failed healing state. Let me give you the evidence by tendon location, because it's not the same everywhere. Rotator cuff, 30 RCTs, approximately 2,500 patients. PRP significantly reduced pain and improved function short-term versus placebo and corticosteroids. For surgical repair specifically, a meta-analysis of 1,359 patients found PRP at the time of rotator cuff repair reduced re-tear rate from 23.6% to 16.5%. Statistically significant. That's a major outcome. Plantar fascia. A 2024 meta-analysis found PRP superior to corticosteroid injections and shockwave therapy for VAS pain at follow-up. A retrospective study of 140 patients, 93.57% effective at 3 months. Achilles, mixed evidence, but the combination of shockwave therapy pretreatment with PRP shows consistent benefit where PRP alone is variable. The eccentric loading protocol remains essential regardless of what injection is used. Patellar. Patellar tendinopathy is the hardest to treat. PRP shows less consistent benefit than at the rotator cuff. Combination protocols with shockwave therapy and strict eccentric decline, squat loading are the standard. The leukocyte detail, not all PRP is the same. For tendons, leukocyte-poor PRP performs better in most studies, particularly for rotator cuff. Adding inflammatory white blood cells to some chronically degenerated tendons adds the wrong biological signal. This is a preparation detail many clinics skip entirely. In my practice, every tendon treatment starts with diagnostic ultrasound. I need to see what's actually happening. Is this a partial tear, diffuse mid-substance tendinopathy, calcification? These have different treatments and different prognoses. Then we select the right PRP preparation for the specific tendon and pathology. We combine with shockwave therapy when the tissue is fibrotic or has significant degeneration. And we prescribe a specific eccentric loading protocol based on the tendon being treated. The eccentric loading piece is non-negotiable. PRP provides the growth factor signal. Eccentric exercise provides the mechanical environment that converts that signal into organized type 1 collagen. Without the mechanical loading component, you're giving the body half the information it needs. Results take time. Realistic patient expectation, meaningful improvement at 6 to 12 weeks, maximum benefit at 3 to 6 months. Patients who give up at 4 weeks are quitting before the biology has had time to work. Chronic tendon pain is not a character flaw. It's a biological reality. Structures that don't heal well without the right intervention. The good news is that we have tools that work with the biology of tendons in ways that cortisone never did. If you're dealing with a chronic tendon problem and you want to understand what your options are beyond another cortisone injection, the link to schedule at Pravida Health is below. Subscribe for more evidence-based content every week.